Good afternoon, everyone.
Good afternoon, ma'am.
I'm Dr. Sneha Wagh from Aurangabad.
Yes, ma'am.
हा मॅडम, हू हॅज नॉट कम, नाही आलेत का अजून लोक? हॅलो.
हॅलो.
हा, म्हटलं कोण आलं नाही अजून?
आलेत करायचं सुरू.
हा, मी तुमच्यासाठीच थांबले होते हो.
So good afternoon all.
हा.
On behalf of Maharashtra University of Health Sciences Nashik,
हम्म.
I welcome you all for online clinical meeting. And today's topic is childhood asthma. So present with is I would like to discuss N. Ramesh. He is PG scholar from Guru Mishri Homeopathic Medical College, Jalna. N. Ramesh. Share your screen.
Dr. Karle, if you don't mind, can you just please tell me the experts which are there for the clinical?
For this we have Dr. Komal Shah.
Hi.
Then Dr. Sonal Sonal Andapurkar.
Okay.
There is name Sheetal Andapurkar, but she is Sonal Andapurkar.
Okay.
And next is Sneha Wag, Dr. Sneha Wag. Dr. Sneha Wag are there. Okay, so these are experts.
From which faculty?
Dr. Komal Shah from Modern Medicine, Dr. Sonal Andapurkar from Yoga and Ayurved, then Dr. Sneha Wag from Homeopath, and Ramesh from Homeopath. Present case.
And Menka, Dr. Menka.
Ma'am?
मला एक स्क्रीनवर डॉक्टर मेनका कोणी ओके. ठीक है, let's begin.
So Ramesh, your screen is visible now. You can present your case. Please unmute yourself. Dr. Ramesh. We have 300 capacity of Zoom link. So it's request to all students, please join YouTube live stream link.
I am audible, madam.
Yes.
Hello.
And yeah, you can start.
Okay, madam. Good afternoon, everyone. I am Dr. Ramesh from Guru Mishri Homeopathic Medical College, MD Part 1 Pediatrics, Jalna. Hereby welcome you all for today's online session of clinical meeting. I sincerely thank to our Director Dr. Desarda Madam and University Authority for giving me this wonderful opportunity to be in front of all you. Today, I am presenting.
Volume. Your voice
Hello?
is weak.
Hello.
Raise
Today
your
I am.
computer audio.
Okay, madam. Today I am presenting a case which is more prevalent in modern metropolitan localities, civilization, urbanization, and industrialization, and linked with the allergic condition. Children in living rural areas of development countries and farming communities with domestic animals are experienced with asthma and allergy. Today going to the case, madam. Name XYZ, age 12 years, sex male, 35 kgs, 12 years old boy with vital signs BP 100 by 70 mm of Hg, RR 35 per minute, SpO2 94% in room air, heart rate 100 per minute, temperature 99.6, that is low grade fever. Chief complaints: common cold for last 2 days, cough for 1 day, the cough was dry cough, and each coughing was followed by vomiting. Breathing difficulty for last few hours. Case history: a 12 years old boy weighing 35 kg presented to the hospital OPD with history of common cold for last 2 days and cough for 1 day. The cough was dry and post-tussive vomiting. The child had disturbed night sleep because of cough. He was also having breathing difficulty for past few hours. Past history: there was past history of several episodes of these kind of elements since the last 5 years, often afebrile, which could be managed by allopathic treatment with oral antibiotics and nebulization at home. But for last 1 year, he had been having this problem every month. In between these episodes, child used to be better but develops cough after running or climbing stairs. Family history: the father had same episodes of complaints, similar illness during in his childhood. Vaccination history: as per schedule, the child was vaccinated. Maternal history: the mother had no history of gestational diabetes and pregnancy-induced hypertension, no history of hypothyroidism, no history of seizures. Birth history: normal delivery. Neonatal history: the child was admitted for phototherapy because of neonatal jaundice. Child had breastfeeding for 6 months. Later on, he had artificial feed. Developmental history: no delayed milestones, no developmental delay. Physical examination: an examination, he was responding to questions but had difficulty in breathing. His respiratory rate was 35 per minute and saturation SpO2 was 94% in room air. His temperature was 99.6, that is low grade fever. Hydration was normal, pulse rate was 100 per minute. He had mild lower chest retractions. The systemic examination: respiratory system inspection done in sitting position, shape of the chest normal, mild supracostal retractions are present. Palpation, respiratory movements, prolonged expiratory phase, trachea central, apex beat, normal fourth leftal intercostal space just outside the mid-clavicular line. Tactile vocal fremitus bilaterally equal. On percussion, hyperresonant note is present. On auscultation, polyphonic wheeze sounds bilaterally, bronchoscalar sounds present. Expansion is louder and lower than inspiration. Cardiovascular system: heart sounds S1 plus S2 plus. Murmurs, no murmurs. BP 100 by 70 mm of Hg. Heart rate 100 per minute. That is tachycardia. Alimentary system: for abdomen soft, bowel sounds are present. No organomegaly. No shifting dullness or fluid thrill. central nervous system. Patient is conscious, coherent, cranial and motor system examinations are normal. In differential diagnosis, the common condition masking the asthma include are allergic rhinosinusitis, laryngotracheobronchomalacia, vocal cord dysfunction, foreign body aspiration, GERD, that is gastroesophageal reflux disease. These are the investigations. CBP showing eosinophils count are 10. That is normal limit is 1% to 6%. Here showing 10%. And WBC count is 16,300, HB 12.2, and absolute eosinophilic count is 493, 440 is normal. ESR, first hour 29 and second hour 55. These are the investigation. Chest X-ray showing hyperinflated lung fields found, increased bronchovascular markings or prominence. Diagnosis, the points favoring diagnosis asthma are repeated episodes of cough and breathing difficulty, required nebulization, exercise-induced symptoms, mostly afebrile episodes, positive family history, polyphonic wheeze on auscultation of chest. This case is mild to moderate asthma because the child does not have daily or frequent night symptoms. Positive investigations. This is the case. Hello?
Okay. So you have next 2 to 3 slides, I think. Left, no? So you can continue. Just show
Okay,
your
I will.
slides.
Actually, I deleted that slides, madam.
No problem. No problem. Thank you.
Oh.
Nice presentation, Ramesh.
Okay,
Now
thank you, madam.
for expert opinion from pulmonologist, Dr. Komal Shah. She is assistant professor, Vasantrao Pawar Medical College, Nashik. Dr. Komal Shah, welcome. Yeah, you can join. Yeah.
Thank you, ma'am. Good evening, everyone. Good evening, Brunal Patil, madam. So nice presentation. So you think it is clear-cut case of asthma, or you think there is any other possibility in this patient? I am asking yes.
Possibilities are there, madam.
Yes. What are those?
Actually, these symptoms mimicking that we already explained in the differential diagnosis: vocal cord dysfunction, foreign body aspiration.
Okay. So in this case,
Right.
Yes. Tell me. Yes.
Hello.
Yes. Yes. I can hear you.
Rhinosinusitis.
So you think it could be foreign body aspiration or vocal cord dysfunction?
Actually, in foreign body aspiration, these are case. These symptoms are present, madam. Wheeze also present, and cough also present.
So there will be fever in foreign body aspiration, you think? So?
No, madam. No
Patient
fever.
is having low-grade fever and it started with lower respiratory.
Dyspnea also present.
Yes, and he started with upper respiratory tract symptoms, right? He started with
Yes, madam.
rhinitis and sore throat, and then it progressed to cough. So
Yes, madam.
foreign body aspiration is less likely, or even vocal cord dysfunction is also less likely. There is no change of voice or any other symptom.
Okay, madam.
And what do you think about if this patient is not having eosinophilia, could it still fit into asthma?
Madam?
If your CBC report would not show eosinophil counts high, then it still is asthma?
No, madam. Actually, one of eosinophilia is also one of the reason for asthma and atopy, madam.
Okay, fine. We diagnose it as asthma, but what in case if there is no eosinophilia, we can still call it as asthma?
No, madam. Frequent episodes we can think, madam.
Okay, so you think that asthma cannot be present without eosinophilia?
Sometimes, madam.
Okay. One more question I wanted to ask. You don't do PFTs in this patient, lung function test? You not mentioned. about
Pulmonary.
it.
Actually, in investigations, I mentioned, madam, pulmonary function test, PFT.
PFT, you mentioned hemogram, X-ray. PFT very short.
Hemogram, X-ray,
Yes,
PFT
is
means
actually very, very important. Yes.
spirometry and
Yes, but it-
forced expression value.
Yes. So what should be the value of spirometry and the expiratory flow rate? It is the main part of investigation, right?
Yes, madam. Yes, madam.
Can we diagnose asthma without PFT?
Actually, PFT lung function decreased in the asthma, madam.
Yes. So can we diagnose it without PFT?
By clinical examination and physical examination, we can tell, madam.
Okay. Ma'am, can I, Dr. Gitanjali, ma'am, can I share my presentation just to make sure, like give some idea about PFT?
Yeah, ma'am. You can share your slides.
So how do I go ahead with that?
There is green tag.
Screen share.
Screen share. Yeah.
But I'm not able to
Okay.
drag
First,
my
first of all, open your slides.
Okay. Slides. Okay.
Okay.
Hmm.
Then share screen. There is an option of share screen.
Ma'am, can you share on my behalf? I have already shared with you, no? Because I am not able to do that here.
It is on Ayush MUHS or what? Which mail?
Yes, yes. Ayush MUHS.
Your slides put there. Yes. I got it. Okay. So, okay, I will share. Is it visible?
Yes, it is visible. But you'll have to press the next every time.
Yeah.
Because I won't be able to do that. Yes, can I start?
Yeah, please.
So today is the topic about the childhood asthma. I am Dr. Komal Shah from Vasantrao Medical College, and I'll be taking you about the asthma from a pulmonologist point of view. What is important from the pulmonology side? Next slide, please. So objective of my talk will be definitely, I want you to know how to define asthma, how can we enumerate types of asthma, predisposing factor, explain diagnosis of asthma, and to explain management of asthma. This is going to be a very short presentation. In short, I'll let you know that how we can do all these things in quickly. Next, please. Actually, I had hidden this slide. Next. So this is actually a very huge presentation, so I'd like to go fast. Next, please. Next. So this is the important definition of asthma. Asthma is a chronic inflammatory disease of the airways which develop under the allergen influence. So here the important thing is allergen influence associated with bronchial hyperresponsiveness. So everybody is exposed to allergen, but there needs to be an allergen, there needs to be an hyperresponsiveness from the bronchial tree. And the obstruction is reversible, and reversible obstruction manifest with attacks of dyspnea, breathlessness, cough, wheezing, and chest tightness. So important three words here: allergen influence, bronchial hyperresponsiveness, and reversible obstruction. Next, please. I hope everybody is able to listen properly. My voice is clear, no?
Yeah, it is little weak, but
Yeah, Komal, you could be a little more clear. You could come closer. I don't know how.
Okay, ma'am. Next slide, please. I'll just go through the important ones. So etiology, as I mentioned, allergens are must in asthma. As asthma is a respiratory allergic disease, the influence of allergen permeated into the organism through airway is essential for the disease development. Now, these allergens could be communal, could be industrial, occupational, natural, or pharmacological. Next. We can see here, there are some allergens which are in our day-to-day practice. We can see in day-to-day life, like house dust mites, then there is like pollen, and food allergies are very, very common. Allergies to pets, their furs and their hairs, then pharmacological allergies to some antibiotics, some enzymes, and allergies most commonly in the form of dust that is collected in the books. These are very common allergens which are around us in day-to-day life. Next. Next. So pathology. Etiology, we learned about allergens. Now this pathology. So exposure to irritants, allergens, and viruses causes two types of response. One is early response that occurs within minutes of the exposure, and the late response which occurs 4 to 6 hours after the initial exposure. Next. So this is very much into detail, but I'll let you know that exposure to irritants and allergens causes activation of mast cells, eosinophils, macrophages, and lymphocytes. This in further leads to release of mediators like histamine, prostaglandins, etc. And what happens ultimately is smooth muscle contraction, vasodilatation, increased mucus secretion, and all these things lead to ultimate thing, that is airway narrowing, which is the hallmark of asthma. Next. Next slide, please. See, here we can see there is, ma'am, one slide. We passed one slide. Yes, here we can see this is the normal bronchial on your left side, and this is on the right. There is hyper-responsiveness. So there is smooth muscle contraction, vasodilatation, increased mucus production, and there is ultimately narrowing of the airway, which leads to the symptoms of asthma. Next. Next. So I'm going in very much shortly because I have been allotted only 10 minutes to present my lecture. So what happens that there is chronic inflammation which is going on for a long time. So when there is acute episodes in between, this inflammation progresses to chronic inflammatory disease. So ultimately, asthma can progress into COPD on a long run if it is not treated properly or if allergens are not taken care of. Next, please. So now classification. So there are many classifications of asthma. We can classify according to etiology, that is intrinsic or extrinsic. According to age, like childhood asthma or adult asthma. According to severity, mild, moderate, severe. Then exercise-induced asthma, which is also very common nowadays. Next. Occupational asthma, which happens only during work time, mostly in factory goers or in farmers. According to clinical stages, the latest is GINA guidelines, that is controlled asthma, partially controlled or uncontrolled asthma, and according to duration of disease, that is acute or chronic. Also, there is called as drug-induced asthma. So this is very important. Asthma severity classification. How do we classify whether the asthma is controlled or uncontrolled, or it is severe persistent? So what is intermittent. Intermittent is when the daytime symptoms are less than 1 per week, or the patient has less than 2 per month nighttime awakening, and the FEV1 and PEF is more than 80% predicted with daily variability of less than 20%. So it is almost normal, then it is called as intermittent. Then we go ahead. When severe persistent asthma, the symptoms are mostly persistent, which limit the normal activities of the patient. Nighttime awakening is almost daily, and FEV1 and PEF is less than 60% of predicted with variability of 30%. Then this is called as severe persistent asthma. So we go like from less than 1 symptom per daytime symptoms per week to more than 1 symptom 1 per week, then daily persistent. It is like that. So the treatment varies as per the severity of asthma. That's why we need to know this, that how do we classify this thing. Next, please. Ma'am, can you? So when do we call it as controlled asthma? When the patient is having asthma control, it is when daytime symptoms are less than 2 per week, when patient is able to engage in normal daily activity, when there is absence of nighttime awakening. There should be no nighttime awakening as a result of asthma symptoms. Then when there is no need of bronchodilator administration or less than 2 per week, the absence of asthma exacerbation, and normal to near normal lung function parameters. This is the point where we want all our patients to be. So if it is controlled asthma, if we are reaching this stage, we can de-escalate our treatment or we can maintain on the same treatment that we are giving. If the patient is not in this stage, then we will escalate our treatment. That's why we must know what is the asthma control. Next, please. These clinical symptoms we are all aware of. Cough, at early it is dry and then it becomes productive. There is more in night and early morning. Tightness in chest. This is important. Why there is tightness in chest? Because our main thing is bronchial obstruction. When there is obstruction, of course, the patient is going to feel chest tightness. Breathlessness, dyspnea with wheezing. Wheezing is again same expiratory wheeze, polyphonic as he mentioned. Why? Because there is again airway obstruction. Allergic rhinitis, sinusitis, itching. Fever may or may not be there. Next slide, please. And when the patient presents acutely, then these symptoms are aggravated. Patient has increased breathlessness, increased wheezing, increased cough, increased chest tightness, then whatever he was expecting in the past. So these symptoms are acute, more than what he was presenting before, and that's why it is called acute exacerbation. Next, please. Next. This I have mentioned. So signs. So when we check for acute asthma, what do we see in the patient? That what is his heart rate? We'll first check the vitals. Then patient is going to have tachycardia. Dyspnea is going to be there. His heart rate, respiratory rate will be high. If we auscultate the patient, there will be wheezing. Respiratory system examination will be bilateral bronchi all over the chest. Occasional cramps. The cramps will not be the important feature of asthma unless there is other symptom like pulmonary edema or anything else associated with it. So main target thing is bronchi, expiratory wheeze. Next, please. So what do we do? How do we diagnose asthma? So I specifically asked the PG resident about eosinophils. So CBC we will do to rule out eosinophilia and to look for any other infection if there is leukocytosis or any other sign. But eosinophilia is not mandatory to diagnose asthma. Asthma can be diagnosed even in absence of eosinophilia. So not all the patients will present with high eosinophil counts, though most of them will be, but absence of eosinophil is also seen frequently. Why do we do sputum in these patients? We want to rule out whether there is any other illness is there, tuberculosis, pneumonia, any other infection is there. Serum IgE, X-ray chest, ECG, and spirometry. Now, this is the most important part. Spirometry, peak flow meter examination, and computerized pulmonary function test. Next, please. Next. This I have already spoken. So X-ray chest here, as he rightly said, we can generally in patients of asthma, they are presenting early in the childhood. X-rays will be normal. It will be, won't be any only prominent bronchiovascular marking which we see in all the patients of respiratory illnesses. So there will be no specific signs of asthma on X-ray in a childhood patient. But if it progresses, if it is chronic asthma, then there will be signs of hyperinflation. Next, please. So these are the signs of hyperinflation. In hyperinflation, there will be hyperlucency of the lung field. It will look more dark, more black. The diaphragm will be low because diaphragm goes low for there will be more air in the lung. There will be expanded intercostal spaces and rib position will be more horizontal. Next, please. Next. So peak flow meter. Now this is very, very important. Whenever we are seeing any patient with asthma in OPD who is stable, we should always check for peak flow meter. This is like thermometer which we are using in medicine. Okay, it is a simple method. It is very economical and it is important for monitoring and assessing prognosis of asthma. This is for prognosis. This is not for actually diagnosis. We can say that there is airflow obstruction with this, but peak flow meter is mainly used for prognosis purpose. I'll tell you how. Patient himself can also do that. Next, please. So this is the peak flow meter. Next. Next, please. Yes, these are the various types of this peak flow meter. Next, I'll explain you how to use this and how the patient can perform. So first, patient has to exhale all the air. The peak flow meter arrow is there, and then they have to blow in the peak flow meter. So they'll get one reading. Now, patient has to mention this reading in a diary every day, morning and night. So when there is variability of 12% in peak flow meter reading, from the patient's point of view, patient can say that there is this is the time when there is starting of exacerbation. So peak flow meter, if we are doing this regularly, we can catch the exacerbation before it worsens. So we can change our treatment at that point. So every asthma, every childhood asthma patient or adult asthma patient should have a peak flow meter with them at their home. And they should be regularly monitoring it in the morning and in the night. Next, please. Next, normal value is in male it is 500 ml and in females it is 300 to 500 ml. There is variation in peak flow meter during date times, age, sex, height, etc. Next. Next, please. Next. So this is how we have to use that. Next, please. Now this is the very, very important thing. As pulmonologists, we never diagnose asthma in absence of pulmonary function test. It is the must thing to diagnose obstruction in the lung. So what happens in pulmonary function test? We are looking for FEV1, that is forced expiratory value in first second. What happens when there is obstruction in the bronchi? When the patient tries to exhale, there is some air trapping in the lung, and that's why the FEV1 decreases, FVC, forced vital capacity decreases, the ratio also decreases. So when the ratio decreases, FEV1 by FVC is less than 70%, it is called as obstruction. And what do we do after that? We give bronchodilators to the patient and we repeat the test after that. So if there is reversibility in the result, so for example, if the patient had obstruction initially, but then after giving bronchodilator, there is 12% reversibility or 200 ml of reversibility, it means it is asthma, because asthma is a reversible condition. But if it is COPD, there won't be any reversibility in that patient. So with the peak flow meter, we can say whether it is obstructive or restrictive disease. And if it is obstructive, whether it is reversible or not. And if it is reversible, then it is asthma. So this is the gold standard for diagnosis of asthma. Next, please. This is the graph we get when the patient inhales and exhales in spirometry. Next, please. So this is how it is seen in obstruction. When there is obstruction, the FEV1 decreases, FVC decreases. This is restriction. where you can see that the lung shrinks like this, and this is the mixed picture. Third is the mixed picture. Next, please. This is how the normal spirometry report is. So here it is very small. You may not be able to see it properly, but here we see the reversibility also. Then second readings are with the reversibility. So if there is 12% plus 200 ml reversibility, we can surely say that this is asthma. Next, please. So why do we do pulmonary function test? Not just for the diagnosis of asthma, but we can also explain the severity on the FEV1 grading. So if it is 80 to 50%, it is grade 1, 2, 3, 4, such way. And we can also monitor the response to treatment when we are giving bronchodilator, whether the patient is responding or not. Or once you have put the patient on some treatment, then you do repeat the pre-FT after 1 week, after 1 month, and whether the patient has progressed or showing some improvement in PFT. So we are doing it for diagnosis, to know the severity, for the monitoring the response of asthma, and of course, as I mentioned earlier, to differentiate between asthma, COPD, and other restrictive lung disease. Next, please. Next. Next. Madam, do I have time to go ahead or should I stop? Like I was given only 10 minutes.
Left, or maybe you could.
I can't hear you, ma'am.
I said if you could directly go to line of management.
Okay. Ma'am, please forward this. Yes, asthma management. So what should be our aim of managing asthma? Our aim is not just the acute management. What if the patient comes, we are giving bronchodilators and patient would be fine. Our aim is to prevent acute exacerbation. So the patient who is coming here, the child who is coming here should not come next time with exacerbation. He should come for follow-up but not for exacerbation. We want to reverse the acute episode. Of course, when the patient comes, we want to reverse the acute procedure episode to maintain normal bronchial physiology, to take care of psychological function, and to minimize hospitalization and maintain normal activity level. Next. So there are various guidelines. The most widely used is GINA guidelines, Global Initiative of Asthma. There is BTS, ATS, and National Institute of Heart, Lung, and Blood guideline as well. But GINA guideline is the most used worldwide. So the key here is patient education. Whatever medicine you are going to give the patient, if patient is not avoiding the allergen, there is not going to be any cure for asthma. So for the key is patient education, the environmental control, and medication. So again, in medication part, if patient is not taught properly how to take medication, then the medication is going to fail. So this is the most important thing, which is patient education. Now, as I mentioned earlier, this is the most important part. Here we are seeing, as we are leveling asthma as controlled, partially controlled, uncontrolled, or exacerbation. I mentioned earlier how to differentiate between this, right? So if the patient is on controlled mode, here we will observe the patient for 3 months, and if patient has achieved this level, we can de-escalate the treatment which we are giving. If the patient is having like last time the patient's FEV1 was better than this time, then we will escalate the treatment. Now, how do we start the treatment? So very nicely here the chart is given. Stepwise approach is there, step 1, 2, 3, 4, 5. And here we can start with, as they have given, we can start if the patient is stable and only requiring SOS base of medication, we can start with SABA, that is short-acting bronchodilators. And we can SOS give the SABA and ICS, that is inhaled corticosteroid combination. If the patient is requiring more, then we can give low dose of ICS and plus SOS whenever the patient is requiring treatment. Stepwise, we can increase the dose of inhalation therapy. We can combine steroids with SABA, the bronchodilators, and so on. But for that, we must know where the patient stands first and what treatment we can start at this stage. So for example, if the patient comes here to me and I feel that patient is requiring ICS plus LABA combination, I will give this treatment to the patient for 3 months. Patient will follow up in between. After 3 months, I'll assess what is his lung function test, how is he clinically, how is his activity level, and if the patient has attained the control level, then I will step down the treatment and I'll give low dose of ICS along with LABA, or if required, after 3 months, I'll give only low dose of ICS. But in this case, if the patient has not achieved the control level, we will again assess whether patient is taking medicine properly, whether there is another allergen in the air, what is happening with the patient. After ruling out everything, if we find that patient is going in exacerbation, we will step up the treatment and we will increase the dose of steroid ICS that we have been given. Next, please.
Ma'am, please conclude now.
Okay. So, in my conclusion, I would just say that we need to diagnose asthma not just on the basis of eosinophils or allergy. It is the multidisciplinary thing. We have to look for etiology, pathogenesis, and pulmonary function test is a must to diagnose asthma. Treatment-wise, we have many options. I could not go for further slides, but inhalation therapy is most important in asthma. Nowadays, we are not giving any oral treatment for asthma because inhaler treatment goes directly in the lung. It has less side effects. It is very as effective or more effective than systemic treatment. Allergen avoidance is a must thing. For that, we need to educate our patients, and it should be along with the exercise and other oxygen supplement and things like that, pulmonary rehabilitation. We should also vaccinate our patients who are progressing to COPD and having long-term asthma. Vaccination should be pneumococcal and influenza vaccination. Thank you.
Thank you so much, ma'am. And sorry for interrupting you.
No problem.
So today is 21st of June and it's International Yoga. So it's mandatory for us to take expert opinion from yoga expert, Dr. Sonal Antapurkar. Dr. Sonal Antapurkar, are you there? Dr. Sonal Antapurkar?
Yeah, hello, ma'am.
So Dr. Sonal Antapurkar, she is professor and head of Swasthavritta Department, RJS Ayurved College, Kopargaon, Ahmednagar. Welcome, ma'am.
Thank you, doctor. So should I start?
Yeah, please.
Basically, it was an excellent presentation by Dr. Ramesh, and it's my pleasure to present in front of Honorable VC ma'am, Dr. Patil ma'am. Thank you so much for giving me such opportunity. I would like to share my screen. Just a moment. Am I audible? No. Hello.
Yeah, I said I'm Dean Academics at the university. I'm not the Vice Chancellor. Please.
No, ma'am. Madhur ma'am is also present. That's why I told.
Yeah,
Okay.
I'm also there.
Yeah.
And I'm listening on because this is pediatric asthma is my favorite.
It's my pleasure having both of you.
Yeah. Thank you so much. I'm on listening mode, huh?
Yes, ma'am. Just a moment. So I'm going to present my views regarding Ayurveda and asthma, childhood asthma and Ayurveda. So asthma is a bronchial asthma, the most common chronic lung disease, as Dr. Komal has said already. The condition is described as stomach shwas in Ayurveda, with the symptoms like abnormal breathing pattern, chest tightness, difficulty in breathing, wheeze and cough and all that, and exertional dyspnea and everything that Dr. Komal has already elaborated very well. But as such, there are 5 types of shwas. Whatever asthma is called in Ayurveda is shwas, described in Charak Samhita in 17th chapter in Chikitsasthan. This disease is basically Vata Kaphatma. Vata and Kapha. Both doshas are got vitiated in this disease. And there are 5 types, as I have told, namely Mahashwas, Urdhashwas, Chinna Shwas, Tamak Shwas, and Santamak Shwas. So from amongst these 5, stomach shwas can be correlated with bronchial asthma. And as per these stomach shwas symptoms and everything, we are going to discuss these cases. When Vat is vitiated by cough, Shwas is produced, that is obstruction of respiratory system. In Marathi or in Ayurveda, it is called as Pranavaha Srotas, that is respiratory system. So, causes are already been discussed, like viral infections, exposure to pollutants, allergy to pollens and all, cold and weather changes, excess physical activity and stress. Actually, these causes are according to modern science, but to our surprise, we have got hetu or causes. Hetu is the Sanskrit name for causes. Hetu or causes are depicted in Sarthavak, but are in Ayurveda 5,000 years back. Like here, I have taken a picture from Sarthavak, but Nidanstham. Rajo, Dhuma, Anila, Marma, Ghata, Ati, Hima, Ambupan. These are the hetus or causes of this asthma. So Raja is dust, Dhum is smoke, Anil is wind, and this causes Marmaghat, that is thoracic injury, and Ati Hima Ambupan means like ice cold water intake. So these all turn to these are all cause to 5 types of asthma, amongst which we are discussing stomach shwas. So coming directly to treatment part, because symptoms and everything is nicely discussed. So pre-treatment and actual treatment, these both parts are there in Ayurveda as per Ayurvedic therapy. I'm going to discuss yoga and its miraculous results, but before that I have about 3 to 4 slides about these all. So pre-treatment procedures include Snehan as well as Swedan. Snehan is oleation with oil, especially in asthma. Oil is processed with lavan or rock salt especially, and then over the thorax, this oil is used to massage. Actually, it provokes stagnant kapha in the body, and later on we are doing Swedan, that is Nadi Swedan, this procedure. It is tube fermentation, especially this steam is passed through the pipe. That's why it is called as Nadi Swed. Because of this Nadi Swed, it has got a high penetration power and heat. It liquefies kapha and expels it to the gut. This is the theory of Ayurveda. We cannot in this short duration, I cannot explain how it goes to gut and how it is eliminated, but these are the basic principles of Ayurveda. Then when it comes to gut, main treatment arrives, that is cleansing and shodhan. So cleansing in the case of asthma, we used 2 therapies like Vaman and Virechan. Vaman is therapeutic emesis and Virechan is therapeutic purgation. So these are Panchakarma therapies from Ayurveda side. Coming to the other part, herbal remedies. I'm going to discuss 3-4 drugs here, which will be helpful as a single drug therapy as well as combined therapy. So most commonly used is Savarchaladi Churna. It is Savarchal salt, that is black salt. You can see the image. I have downloaded it from net. Clerodendrum ceratum, and then Sharkara. It is not a simple sugar which we use in day-to-day practice, but it is Khanda Sharkara or Khadi Sakhar in Marathi. So these all ingredients are made in powdered form and advocated with honey, so as to get relief from the symptoms like wheezing and all the asthmatic symptoms. The second one is Shatadi Churana. Again, I have shown you the images because we all are aware that we found these herbs in front of everywhere in the surrounding, but we don't know how to use them. So Hedychium spicatum and Inula racemosa, that is Pushkarmur, these both drugs or herbs can be used in again dried form with honey. Then third drug is Emblica officinalis, that is Avla or Amalaki we call it, and Dashamul decoction, we already know it. So these are herbal remedies. Again, a potent remedy from Ayurveda side is Vasa decoction. Adha Thoda Vasika is immunomodulator, Haridra, as we know. Haridra and Tinospora cordifolia, that is Gudvel or Guduchi, which we are very well acquainted, familiar during the period of COVID. Then Dhanyak is coriander, Pipali, we know it, Shunki and Solanum xanthocarpum. It is called Kantakari in Marathi. We found it by roadside. Everybody has seen these beautiful flowers with horny plant. So these are the content of Vasa decoction, which is being used effectively in the management of asthma. Then coming to the part Yogasana, I have got a few references. An article published in Indian Journal of Traditional Knowledge. It has been, they have done some research, like a group of asana they have found, Gomukhasan, Bhujangasan, Chakrasan and Dhanurasana. These 4 types of asanas are found to be beneficial for the children associated with asthma, especially these asanas, Gomukhasan, cow face, and Bhujangasan, cobra, Chakrasan, wheel. So, if we look into the postural changes of body of these asanas, we will find that chest is widened, expanded, thoracic cavity is expanded, and lung capacity is also expanded, vital capacity is increased. So, like in this picture, Gomukhasan, this region, shoulder region is widened. And in Dhanurasana, bow pose, again, same thing, musculature. This is Bhujangasana and Chakrasana. So all of these asanas add to the flexibility of intercostal muscles, pulling of intercostal muscles, and expansion of thoracic cavity, so as to make it more easy to enter air into the thoracic cavity, and to make the more air available in the lung to be exchanged. Then coming to the next part, that is pranayam or some breathing exercises. Pranayam is a typical part, characteristic part of yoga abhyas. It is like Yaman, Yam, Asan, Pranayam. It's the 4th part of Ashtanga Yoga. It can be defined as Tasmin Sati Shwasa Prashwasa Yor Gati Vichchedaha Pranayama. So Shwasa Prashwasa Gati Vichched. It's very simple to understand. Shwas, inhalation and exhalation. The speed of pace of inhalation and exhalation has been reduced in short, and that process is called as pranayama. And accordingly, then pranayama can be classified into 8 types: Surya Bhedan, Ujjayi, Shitali, Sitkare, Vasrika, Brahmari, Murcha, Plavin. Iti Ashtakumbhaka. 8 types. These are 8 types. Then again, I encountered one research paper. Actually, not this. It was my research paper actually. Last year I published it. Immediate effect of Bhastrika Pranayam on arterial oxygen saturation. This was published. So Bhastrika was found to be effective in increasing lung capacity, vital capacity. It brings dead space into use. It helps in the sinusitis, bronchitis, and it, as I told earlier, increases arterial oxygen saturation. It is Bhastrika is rapid inhalation and exhalation. So as Dr. Komal said, it can increase forced expiratory volume, Bhastrika Pranayam. So even Baba Ramdev or various yoga gurus have made it popular. Still, I would like to just show a demo, not exactly demo, but the procedure of Bhastrika Pranayam. Bhastrika is like sitting straight on the floor in Vajrasan, Padmasan, or a simple Sukhasan. Then having the fist like this, arms stuck up to the body, to the torso, and then upwards, inhale deeply and while bringing them to downwards, one has to exhale. So inhale, exhale forcefully. So usually people do what? People not this type of. We have to stretch this shoulder part, then bring the hands upward, inhale deeply, and while bringing, exhale deeply, forcefully. So this will what we can call increase the duration of gases exchange, and hence it leads to increase in arterial oxygen saturation as well as forced expiratory volume. So Basrika is found to be very useful and potent treatment, preventive treatment, in fact, in bronchial asthma. Then another one research paper I found, International Journal of Yoga. It has been published from Ajmer Medical College. They have selected 5-6 procedures, yogic procedures like deep breathing, Shashankasan, Anulom Vilom Pranayam, Brahmari chanting, Omkar. So Brahmari and Omkar, as per our opinion or our yogic sciences, both have got prolonged exhalation. So due to prolonged exhalation, it enables trapped air to get expelled out of lungs because of prolonged exhalation. So these certain group was asked to practice these group of asanas or yogic therapies for 6 months. Before and after results, forced expiratory volume FEV was less than 85%, but afterward it was found, this research was found to be very significant. So again, this group of asanas and Brahmari as well as Omkar were proved to be very effective. In addition to that, stress is one of the factors to exaggerate asthmatic symptoms. So Omkar and Brahmari pranayam also reduces stress at up to certain level. A wonderful book published by Dr. Swami Ramaswamy from Himalayan. Now he is not actually alive, but very good researches regarding Omkar sadhana and meditation are depicted in that book from meditation. Yes.
I am sorry to interrupt, but I just wanted to know how you're in pediatric asthma, how do you
Yeah.
go about doing all this?
Okay. So after next, yes,
Small
ma'am.
child to do all this.
Yes. After 6 years, one can do practice everything from this yoga. As a child is able to play everything, every skillful game, he is able to do every asana. But again, if baby is very small, like 1 year or 2 year, we have got excellent remedy, which I am coming to that point. This is from Shatkarma Niti, Jalaniti. It is used for again for prevention or for congested sinuses. In this process, use of lukewarm or saline water. We take like 1 liter of saline water, lukewarm water, and if you are knowing this process, then I am not going to explain it again. But saline water pool can be done or is practiced in the kids also, or small children also, up to 1 year, 2 years. So we can adapt this therapy for the for these children also. So that it's useful in congested sinuses, cold, allergies, rhinosinusitis, especially in pediatric group 2. So it was again a research paper. And I have last slide, how it helps in allergies like Niti, especially Niti. In Niti, saline water pool can be administered in children. Just wash of saline water will help, and it will serve the function of Jalaniti. But when adults are going to do that after 12 years or 10 years, boy, girl is going to do that, one has to touch her or his ear to the shoulder, and from opposite nostril, one has to insert that specially designed neti pot and pour the lukewarm water and let the water come from other side through the ethmoidal bone and all, and then the sinuses get cleaned with this process. The next slide is how it helps in allergies. So Dr. Komal has already explained it in a short. The same explanation is given here. Inhaled allergens pass through the nasal mucosa and come in contact with IgE antibodies. The resultant antigen antibody interaction triggers mast cells which release histamine and which are responsible for allergies. But the sinus rinsing, which we do in the kids, will help to eliminate histamine and other allergens through the nasal passage, and thus this neti helps us. So these were all about the procedures and miracles from Ayurveda and yogic sciences. So for the students, somewhere something incredible is waiting to be known. So dear students, always do experiments, fail, repeat, learn, and thank you so much, ma'am. That's all from my side.
Thank you so much, Sonal ma'am. Now we have today Master of Experts with us. So, Honorable Vice Chancellor, Dr. Lieutenant General, Dr. Madhuri Kanetkar ma'am is here. So, ma'am, would you like to add something?
Thank you so much. No, I'll just add that firstly, it was an excellent presentation by Komal. Komal, you're from which faculty?
Ma'am, I am a pulmonologist. I have done DNB pulmonology from Tesla Hospital in 2013, and now I am working with Vasanta Pawar Medical College.
Oh, because it was absolutely, exactly what we keep trying. And I was telling them that it's important to know that we are now even going slower on bronchodilators and more on not to let remodeling occur. In fact, I had mentioned that to Gitanjali. So I'm really happy that you brought in concepts of PEFR and, how the capacity, so that the basics have been very well understood. But we, like you correctly brought out, except for inhaled corticosteroids, we don't have any other major preventers. Probably, we are using things like Montelukast and this. So these are the only two groups we are really using, no?
Yes,
Is there anything else?
It is like that, ma'am. We have xanthines and we have chromes, but they are not that useful. So prevention is the most important feature.
Yes. So I think
And
that
now,
is
I could not come to that slide, but now we have immunomodulator therapies also. That is very advanced stage when we find out only single allergen. If we can find out only single allergen in a patient, then we can give the immunomodulator therapy in those patients.
Yeah, but that happens very rarely in our Indian settings, and we find more and more. And the second thing I'd like to share is that we are having more of these increased allergic responses because we are changing our response, with better immunity, less of infections. Like there is something called a Th1, Th2 response, which is, there's an imbalance which occurs. And as infections are coming down in society, we are seeing more and more allergies. And pollution, I think, is the biggest problem which has created, and young children are really developing this. So I think it was very beautifully brought out. And Dr. Sheetal, thank you so much. I think you brought out very interesting, because even in children, we do see children, there's like a spectrum disorder. They start with atopic dermatitis in childhood. They get these skin allergies, and then they have the childhood asthmas, and they have the allergic rhinitis. So you have all these things which get clubbed together. So I guess in cases where specifically it is your respiratory thing, we might be able to use the Jalaniti that you explained. But that is more, we are using it regularly more as ENT, this thing with the adults. And what we are using is more than saline. You get ready containers in the market today for, which are squeeze bottles, and the same position, and we have bicarbonate, sodium bicarbonate and salt mixture. So it becomes isotonic, and that is used for nasal flushes. But it would be a word of caution, because we wouldn't want, children to yeah, because their sinuses are still developing. All the sinuses are not there in very young children. So we wouldn't want people to try something. It should be, if at all, recommended by experts, and they shouldn't start doing that to children. And in pediatric, I think inhaled corticosteroids remain our best, and the prevention of known allergies. And I think house dust happens to be the biggest criminal, and your food additives, food these things, even simple things at home, which we advise, ki when you're sweeping, if it's a dry jhadu that you're doing, it should be when the child is not at home, because it causes a lot of rising of pollens and the dust mite, which brings on an attack. And I think if the message goes of earlier, there were a lot of use of those nebulizers. So people kept at home nebulizing, and then they keep on nebulizing. So that, I think, am I right, Komal? We now advise that don't keep doing it at home. Start getting into preventers quickly.
Yes, ma'am. So nebulizers work as good as inhalers. So inhalers are at par with them. We use nebulizers only when the patient is not able to inhale.
Yeah.
That's the only point where we are using, because
Yeah.
they are port of infection. No, if it is not cleaned properly, it will go directly in the
Yeah.
lungs.
And from my experience, I feel people misuse antibiotics a bit too much.
Yes.
Most of these are allergic disorders, and they would have occasional fever as an inflammatory response. So we should not start giving amoxicillin and all sorts of antibiotics to children. We should stick to, if we are known, it's a known, once diagnosed as childhood asthma, I think starting with inhaled corticosteroids becomes the cornerstone of preventing worsening. I thought that was something I can only add.
Yes, thank you, ma'am. It was perfectly good, actually.
Thank you so much, ma'am.
Thank you so much, ma'am, for your inputs. Now we have Dr. Sneha Wagh for our today's last expert opinion from homeopath. Dr. Sneha Wagh.
Good evening, everyone. It's honor and thankful for the MUHS team and VC ma'am also to give me a presentation and also to be an expert in homeopathic faculty through. I would like to highlight your, the view that on homeopathic treatment for asthma. So the case presentation was very well done by the sorry for the disturbance.
Ramesh.
Yes, Ramesh. And after that, I would the sessions were very good with Dr. Komal ma'am, Dr. Sheetal ma'am also, and very much enlightened by the VC ma'am also. Okay, now not wasting time, I would like to highlight something, points on the homeopathic treatment for asthma. So we have got very minute case taking done, and the case taking involves detailings like how is the cough, what is the time of aggravation, what are the different types of modalities, we call them as aggravating factors, ameliorating factors. Now allergen is one of the type in this, understood, but even we take the detailed history for exactly how is the asthma when the cough is present with any excessive difficulty in breathing, how is the cough, how is the mucus, when is the nasal obstruction. So the time modality is very important for us in the case history in the considering the homeopathic treatment. So I would like to highlight some few medicines. One is Sambucus nigra, is nightly suffocative asthma in children. If it is night aggravation, then Sambucus helps very nicely in this case. If the child suffers from cough with excessive difficulty in breathing, the expulsion of small amount of tough mucus and nasal obstructions are the typical symptoms of the Sambucus nigra. Then after that, Natrum sulph. Natrum sulph is an excellent homeopathic medicine for childhood asthma. If there is rattling cough, dyspnea with mucus in chest, or if the mucus is greenish color, then we go for Natrum sulph medicine for the choice. Then after that, one more medicine I would like to add is arsenic album, which is useful when extreme difficulty in breathing due to constricted air passage. with wheezing in chest, aggravation of asthma when going to bed or during midnight aggravation. So when these conditions are there, we prefer for arsenic album. Next medicines I would like to highlight, that is one of the medicine, that is Sina, where the cough with asthma that ends at vomiting. Means if the patient has asthma and ends the cough with vomiting, then this Sina medicine is very useful in this children's case. Then we have another medicine, that is Cupramet, where there is spasmodic cough, violent fit of cough with vomiting, and there is cold face with blue lips. This is a very marking point, which I think the allopaths don't see. But the details, that is if the face is bluish or the lips are bluish, or how is there any condition with cough and vomiting. And sometimes even the parents are not giving proper history. So it is also very difficult to diagnose cases of asthma in children. So this is also one more point I would like to highlight. Then there is one more medicine we have got, Spongia tosta, where there is dry, barking cough, suffocation, and short breath with difficult respiration, and there is night aggravation mostly. Then Spongia tosta is also one of the fine medicine to act on. Then one more medicine is there, that is Lobella inflata, which is useful in wheezing with asthmatic conditions. Then we have Antim tart, where there is wheezing and rattling with mucus. Then we have Antim tart as a choice of medicine. Then there is also one more medicine, Blata orientalis, where the cough with pus like mucus, and if the child is fatty in constitution, then we use Blata orientalis. Then one more medicine I would like to add is Ipecac, where there is asthma in children with violent wheezing cough and chest seems full of pulgum, but does not come out on coughing also. So there, Ipecac will help for the patient to get relief. Then one more medicine I would like to add, that is Absidosperma. This medicine is considered as a tonic for the lungs, which removes temporary obstructions of the oxidation of blood by stimulating respiratory centers. So this medicine is very useful in cardiac asthma also. So these are some few medicines which I have highlighted, and I would like that the time given was too short. So my presentation
Thank
is
you, ma'am. Dr.
Thank
Sneha
you.
Paul, she is professor and head from SB Homeopath College, Aurangabad. Thank you so much. Now to
Yes.
conclude session, I will request Dr. Mrunal Patil, Dean Academics. Ma'am, please.
Thanks, VC ma'am, for your inputs. As Madam rightly said, yesterday she just said that the modality for treatment has changed and now it's more become inhalational steroids. And I also said, let's see what the expert says tomorrow. And Komal, good you could come out with the latest guidelines for the management. And thanks to inputs from both my colleagues in the Ayurveda and the homeopathy field. But being new to this online lecture series, where because of VC ma'am, we have this integrated approach towards management of a patient, and that now a pediatric case. I'm really I do have I am a little confused and I really do not know. But I just want to know, like, when really a pediatric case comes to you, you stick to your own. Do you make use of inhalational steroids along with your own line of management?
So, ma'am, we try to follow the guidelines as much as possible because they are really very much working.
I'm not asking you, Komal. My question was for our Ayurvedic and homeopathic colleagues.
Absolutely.
So, ma'am, give me permission to talk.
Yes.
I would like to highlight on homeopathy. We have very minute rubrics to be asked to the patient, and we use, for example, we have got a book called Repertory. In this repertory, we have all the drug provings done, and all the rubrics are mentioned in that in such a minute details. For example, I'll read one rubric. For example, we have asthmatic midnight after 3 a.m. Then we can give Kalika. So we have got specific time modalities, and we want that, and that individualization. Individualizing symptom of that patient is very important for us. So when we are taking case taking, we need mentals, we take physical generals and also particulars. But we are mostly highlighting with the time modalities. If there is specific time modality, if the patient is aggravating at night, at morning, at evening, we have got very specific medicines for that, which are very useful in these conditions. So I would like to say that these modalities are very helpful for us when we are taking a case.
Yes, ma'am. This is Dr. Sonal. As well, as she said, in our pathy also, we used to do these, we used to follow all our modalities as per stated. Actually, we have got a separate subject like Balrog. So we can follow these guidelines and treat the patients.
I think that, can I come in, Dr. Pratil? I think, the points brought out by them are very good. When Dr. Wagh also brought out, and this thing, that when we move for, no two children are alike, no two adults are alike, no two diseases are
Yes.
alike, no allergens are alike. And we
Yes,
are,
perfect.
there's what we don't know. So I think it's a very good thing that precision medicine is moving towards personalizing. And they have more detailed rubrics and they spend a lot of time on picking up.
Yes.
I've personally
absolutely.
experienced this. I had a TM joint spasm. And, I went through MRI, through everything, and the only thing that was painkillers. But when I went to a homeopathic, colleague, there was so much history, this thing that was taken, including the way I sleep at night. And there was certain work pressure at that time. And he said that is what he took from birth to that and spent 2 hours in history taking. So I understand what you're saying. And I think it's brilliant if through we learn from you how to take detailed history and then look at it and we share. But at the end of the day, I mean, yes, if you're treating, but my take home message would be that at any point you feel, or any students who are listening, that while you do your own treatment, what are the red flag signs where you would say quickly, not go beyond? I think that is an important point to learn. And if you find the child is getting drowsy, that means oxygen is not, because in none of this we're talking, whereas hypoxia occurring in a strike spasm, it's going to be the biggest danger. And we're not really, in every pathy, we don't look at pulse oximeters to see. So if you have a rough guideline that if a child is getting drowsy, if he's constantly vomiting, because like you said, IPCAC is basically causes emesis. Emesis is a stronger reflex of coughing. So that means there is a lot of phlegm, and there's probably, besides your bronchospasm, there's something stuck and it's trying, if you can bring that out,
trying to expel out.
it relieves temporarily. So, but if you find continuous vomiting, child getting drowsy, the breathing rate going on increasing, and if you don't have peak flow meters, you can do a single breath count, and if you find that an older child or a younger child whose nostrils are getting flared or the rib cage is getting indrawn, that's the time not to keep on trying something, but to rush him for
Emergency.
oxygen and giving him the steroids. So I think if we all practice that way, that yes, we each one have our roles. The clinician, allopathy starts off with inhalational steroids. If it's a mild attack, homeopathy goes into real details, tries it. Ayurveda has, and we are also encouraging. I mean, I've practiced where I would give children balloons and whistles to improve their lung capacities. So we are all talking similar physiology. But what we need to do is know when to help each other and work as a team, because the child has to get well. So we don't feel, and we don't try to start treating each other's. So if you find, yes, the child under my care, but look, you'd like to have a good friend amongst yourself. So in allopath, the person is getting repeated attacks. Tell the child, why don't you look at, have a try if you can prevent with, homeopathy, or Ayurveda helps you with better breathing exercises, because I want you to be well. So let us send them to our colleagues, and they in turn like, look, I've been doing it, but I think it's worsening. I think you need a management. So if we have that spectrum and learn from each other, I think that should be the take home message.
Thank you so much, ma'am.
Thank you.
I think that entire concept of integrated family medicine explained completely well where pediatric asthma is concerned. And I think so many much more cases where, this kind of approach towards any kind of disease could be used. So thanks to all of you all for having joined. Thanks to the resident. The SIP interns were also there. I hope they had they learned a lot from this, and thank you all of you all for being a part of this online lecture series. Thank you.
I'll give my last punchline. I had to use pull to get in. Your lecture series are becoming so popular that how many could log in was all packed. So I had to get my computer team to override. So someone may have got pushed out. I'm sorry, but I've loved this. Thank you so much.
Thank you, ma'am. Thank you.